Welcome to the Deep Dive, your shortcut to being genuinely well-informed. We pack it with surprising facts and hopefully just enough humor to keep you hooked. Today, we're embarking on a deep dive into a really comprehensive set of sources focused entirely on pediatric conditions. Our source material is straight from Pants Prep Pearls V5. So that means we're pulling out the core, clinical details, diagnoses, management strategies, really practical stuff, our mission,
Yeah.
to help you quickly grasp a whole range of conditions from, those super common, often harmless newborn rashes, all the way to complex genetic syndromes affecting multiple body systems. So let's start our deep dive right on the surface, literally. Let's talk about some of those common, often self-limiting skin things in newborns that can sometimes cause, well, a lot of worry for new parents. First up is erythema toxicum neonatorum. Sounds serious, but it's actually benign, meaning harmless. It's a self-limited pustular thing that pops up in newborns, usually within the first, 72 hours?
That's right, the first few days of life. And it's thought to be related to their developing immune system kind of kicking into gear.
Yeah.
Interestingly, it seems more common in babies with a higher birth weight and those born closer to their due date, so greater gestational age.
Okay. And what does it actually look like?
You'll typically see these small red spots or bumps, maybe 1 to 3 millimeters, and they often develop into little pustules, like tiny pimples, sitting on a red base. They're common on the face, trunk, and the upper parts of arms and legs.
But not everywhere, right? There's a key distinction.
Exactly. Crucially, they do not involve the palms of the hands or the soles of the feet. That's a big clue.
Ah, okay.
And that's why the diagnosis is entirely clinical. You just base it on how it looks. The key insight here isn't just that it's harmless, but understanding that avoids unnecessary worry for parents and prevents any potentially harmful, unneeded treatments.
Right. Because you see pustules, you might think infection.
Precisely. But this typically resolves all on its own in about 5 to 7 days.
Good to know. Okay, from one common thing to another, milia, those tiny pearly bumps.
Melia.
Yeah.
Very common. These are basically miniature cysts almost, caused by a bit of keratin, that skin protein, and some sebaceous material getting trapped in the hair follicles. The skin's just immature.
Exactly.
Like tiny 1 to 2 millimeter pearly white or yellowish bumps. Really distinctive. You see them a lot on the cheeks, forehead, chin, and nose.
And treatment.
None needed. Just like erythema toxicum, no management is necessary. It's a totally normal part of newborn skin development. It almost always disappears by the first month, maybe lingers up to 3 months sometimes.
Okay, simple enough. Then there's miliaria, heat rash, prickly heat.
Right, miliaria. This is another transient skin issue caused when the eccrine sweat ducts get blocked. So the sweat can't get out to the surface properly, and it ends up leaking into the skin layers, the epidermis and dermis.
And is there like a bacterial component too?
Well, we do find increased counts of normal skin flora, like Staph epidermidis and Staph aureus associated with it. But it's mainly the blockage. It's really common in newborns, especially around 1 week old, and obviously in hot, humid environments.
Where does it usually show up?
Mostly on the trunk and in those areas where skin rubs together, like the armpits, the groin, intertriginous areas.
Okay, so what actually causes that blockage?
Well, think about things that make you sweat more or block the ducts. So occlusive clothing stuff that doesn't breathe well. Or if a baby has a fever and is stuck in bed. Even certain medications can trigger it, like some beta blockers or opioids, though that's less common in babies. Essentially, the openings of the sweat ducts get plugged up. Then the trapped sweat causes the duct to rupture, leading to that inflammation and that irritating, prickly feeling.
Okay, let's unpack this because you mentioned it depends on how deep the sweat gets trapped. There are different types.
Exactly. There are distinct types based on the level of obstruction. The most superficial is miliaria crystallina. Sweat's trapped right at the very top, the stratum corneum. It looks like tiny, fragile, clear blisters, almost like little dewdrops, very common in newborns.
Okay.
Then, a bit deeper, you get miliaria rubra. This is the most common type overall, what most people call prickly heat. Here, the sweat's trapped deeper in the epidermis. It causes intensely itchy red bumps, not necessarily right at the hair follicles, often on the upper trunk.
Right, that's the classic one.
And then the deepest form is miliaria profunda. The sweat escapes even deeper into the papillary dermis. This causes flesh-colored bumps, usually not itchy. But if the damage from severe rubra or profunda is bad, it can actually impair sweating, leading to anhidrosis.
Wow, so you could overheat?
Potentially, yes.
Yeah.
Anhidrosis can lead to hyperthermia and even heat exhaustion in severe cases.
So management sounds pretty straightforward then, mostly environmental.
Yes, management for miliaria really focuses on reducing sweating and blockage. Simple things. Dress the baby in light, breathable clothes like cotton. Keep them in a cooler, drier environment. Avoid occlusive things like heavy blankets or plastic liners. And of course, treat any fever with antipyretics.
Okay, good practical tips. Before we move to things with potentially deeper implications, let's quickly touch on two other common pigmentary things. First, congenital dermal melanocytosis, Mongolian spots.
Right. Those are those flat blue or slate gray patches, very common on the lower back or buttocks area. You see them incredibly often in Asian and East Indian infants, over 80%. Also
Yeah.
more frequent in Hispanic and Black infants.
And the cause.
It's just pigment cells, melanocytes, that didn't quite make it all the way to the top layer of skin during development. They got stuck deeper down in mid-dermis. The good news is they almost always fade over the first few years of life. No treatment
Yeah.
needed.
And the other one, nevus simplex, stork bite, macular stain.
Yeah, nevus simplex. These are those flat, pinkish red patches. They blanch, meaning they fade if you press on them. Irregularly shaped. Very common locations are right on the midline. Back of the neck, the classic stork bite eyelids, and the glabella, that spot between the eyebrows.
And these also fade.
Most do, yes. They typically fade and resolve spontaneously by about age 2. They don't usually darken over time. Simple observation is key.
All right, so those are mostly transient or benign. But now let's talk about skin findings that might actually signal something more complex going on underneath, like café au lait macule or colmes.
Café au lait spots.
Yeah.
These are flat, evenly colored patches, usually tan to dark brown. They have sharp borders, often oval-shaped, and they grow proportionally with the child.
Do they appear later, or are they there at birth?
They can be there at birth or appear pretty early in childhood. Sun exposure can make them more obvious.
And what's going on at the cellular level?
Basically, there's an increased number of melanocytes, the pigment cells, and more melanin pigment within the dermis layer.
But the real significance comes with their associations, right? Especially with NF1.
Exactly. This is where a simple skin spot becomes a potentially crucial clue. Having 6 or more café au lait macule that meet specific size criteria, which is generally bigger than half a centimeter before puberty or 1.5 centimeters after puberty, is a major diagnostic criterion for neurofibromatosis type 1, NF1, especially if you also see freckling in unusual places like the armpits or groin. We call that axillary or inguinal freckling.
Wow, 6 or more, that's specific.
It is. They can also be seen in other conditions like tuberous sclerosis or McCune-Albright syndrome. Though with McCune-Albright, it's often one very large, unilateral, calm, kind of jagged border sometimes.
Okay, so colmes are pigment-related. What about vascular birthmarks like port wine stains?
Right, port wine stains,
Yeah.
also called capillary malformations or nevus flammosus.
Yeah.
These are due to abnormal development of the tiny blood vessels, the capillaries and postcapillary venules, right near the skin surface. They're dilated. And these are always present at birth. They don't develop later.
And their appearance changes over time.
It can, yes. In infancy, they're typically sharply defined, flat, pink to red patches that blanch with pressure. But as the child grows, they can darken, becoming more purple, and the skin can even thicken or develop little bumps within the stain. They often occur on the face, and sometimes they seem to follow the distribution of the trigeminal nerve.
And like the colmes, these can be associated with bigger syndromes.
Absolutely, that's the key connection. A port wine stain, especially on the face, should make you think about Sturge-Weber syndrome.
Ah, okay. Tell us about Sturge-Weber.
Sturge-Weber is a congenital disorder present from birth. It has a classic triad of features. 1, that facial port wine stain, particularly if it's in the area supplied by the first branch of the trigeminal nerve around the eye and forehead. 2, leptomeningeal angiomatosis. That means abnormal blood vessels on the surface coverings of the brain. And 3, ocular involvement, most commonly glaucoma, increased pressure inside the eye.
So it's not just skin deep. What kind of complications can arise from the brain involvement?
Well, the abnormal blood vessels can cause problems like seizures, weakness, or paralysis on the side of the body opposite the facial stain, hemiparesis, abnormal calcium deposits in the brain, and sometimes learning disabilities or intellectual impairment.
A very clear example of a birthmark hinting at much more complex issues.
Definitely. It highlights why careful examination and follow-up are so important.
Okay, this feels like a natural transition. We've seen how surface signs can point deeper. Now let's really dive into the genetic conditions themselves, the blueprints, starting with chromosomal abnormalities. First, Down syndrome, trisomy 21.
Right, Down syndrome, caused by having 3 copies of chromosome 21 instead of the usual 2. It's the most common chromosomal disorder we see, and it's also the most common genetic cause of intellectual disability.
And it has some very characteristic physical features, doesn't it?
It does. Quite a few recognizable features. In the head and neck area, you might see low-set small ears, a flattened facial profile, sometimes a protruding tongue. The eyes often have an upward slant at the outer corners, and those little skin folds at the inner corners called epicanthal folds. Short neck is common too, and sometimes brush field spots, tiny white or yellowish spots on the iris.
What about hands and feet?
Often a single deep crease across the palm, the simian crease. Joints can be unusually flexible, hyperflexible, and there's often a wider gap between the first and second toes, the sandal gap deformity.
And in newborns specifically.
Newborns often have hypotonia, meaning low muscle tone, they feel a bit floppy, and they might have a poor Moro reflex, that startle reflex. It's also crucial to know about associated conditions. Congenital heart disease is very common, especially atrioventricular septal defects, and certain GI issues like duodenal atresia, a blockage in the first part of the small intestine, or Hirschsprung disease affecting the nerves in the colon.
So diagnosis is usually suspected clinically, then confirmed with genetic testing, like a karyotype.
Exactly. And there are prenatal screening options too, right?
Yes. First trimester screening often involves blood tests looking at hormones like PPA, which is typically low in Down syndrome pregnancies, and an ultrasound measuring the nugel translucency, the fluid at the back of the baby's neck. Increased thickness raises suspicion.
Right. And if screening is positive, then diagnostic tests like CDS or amniocentesis can give a definitive answer by looking at the chromosomes directly.
Okay. Let's move to Turner syndrome. This involves the X chromosome in females.
Yes, Turner syndrome involves abnormalities of the X chromosome. Most commonly, it's the complete absence of one X chromosome, so 45XO. But it can also be partial deletions or other rearrangements. It's the most common sex chromosome abnormality in females.
And the key features.
A major one is hypogonadism. The ovaries don't develop or function properly. This usually leads to early ovarian failure, meaning they don't go through puberty normally, have primary amenorrhea, no periods, and are typically infertile. Physically, short stature is almost universal. Other common features include a web neck, prominent ears, a low posterior hairline, a broad chest with widely spaced nipples, sometimes called a shield chest.
Any signs in newborns?
Yes, newborns might have congenital lymphedema swelling, especially of the hands and feet, due to lymphatic system issues. And importantly, there are associated cardiovascular problems like coarctation of the aorta, a narrowing and bicuspid aortic valve.
Okay, now for males, there's Klinefelter syndrome.
Right, Klinefelter syndrome. This is in males, and it's caused by having extra X chromosomes, so the pattern is 47,000XXY. It's the most common chromosomal cause of hypogonadism in males.
Do they look different before puberty?
Often not significantly. They might appear typical before puberty, although some infants might have hypospadias or a micropenis. The differences become more apparent after puberty is delayed or doesn't progress typically. They often end up with tall stature, but with unicoid proportions, meaning relatively long arms and legs compared to the trunk. Scoliosis can occur. Mild developmental delays, especially in language, are also possible.
And the hypogonadism, how does that manifest?
It results in small, firm testes, gynecomastia, breast development, infertility, usually due to azoospermia, no sperm production, and reduced facial and body hair. And there's an increased risk later in life for certain things like testicular cancer and even breast cancer.
Interesting. Okay, next is Prader-Willi syndrome. This one involves chromosome 15.
Yes, Prader-Willi. It's a genetic disorder caused by a problem with genes on chromosome 15, specifically the copy inherited from the father. Usually it's a small deletion in a specific region, 15q11.213, or sometimes it's because the paternal copy is present but not turned on or expressed properly.
And it has a very distinct pattern, right? Especially the shift from infancy to childhood.
It really does. It's classically described as having 2 phases. In infancy, the hallmark is severe hypotonia. They're very floppy babies. They often have a weak cry and major feeding difficulties, sometimes needing NG tube feeding just to get enough nutrition.
But then things change.
Dramatically.
Yeah.
In early childhood, the muscle tone improves, but they develop this insatiable appetite, hyperphagia. They just don't feel full, which leads to chronic overeating and often severe obesity if their food intake isn't very strictly managed. Alongside this, there are usually significant developmental delays and often behavioral challenges.
Any other features?
Yes. Other common features include hypogonadism, short stature, often due to growth hormone deficiency, and sometimes characteristic facial features. They also tend to have lighter hair and skin pigment compared to their family members.
Quite a complex picture. And the last chromosomal one for this section, Fragile X syndrome.
Fragile X. This is an X-linked dominant disorder. It's the most common inherited cause of intellectual disability and also the most common known genetic cause linked to autism spectrum disorder.
X-linked dominant. So it affects males more severely.
Generally, yes, because males only have one X chromosome. Females have two, so the other X can sometimes compensate to a degree. In younger boys, you might see features like strabismus, crossed eyes, hyperextensible joints, hypotonia, and macrocephaly, a large head. As they get older, post-puberty, more characteristic features can emerge. A long, narrow face, prominent forehead and chin, large ears, and macroorchidism and large testicles.
And cognitively and behaviorally.
There's often mild to moderate intellectual disability, significant issues with expressive language, hyperactivity, anxiety, and sometimes seizures. Females who have the full mutation can have similar features, but often much milder. About a half may have normal intellect.
Okay, that covers the major chromosomal ones. Now, let's shift slightly to genetic conditions affecting connective tissue, the body's scaffolding. Starting with Ehlers-Danlos syndrome, or EDS, which is actually a group of disorders.
Exactly. EDS isn't just one thing. It's a group of inherited disorders that affect collagen synthesis or processing. Collagen is that key structural protein in skin, joints, blood vessels, etc. The classic triad, though not present in all types, is 1. Skin hyperextensibility, really stretchy skin. 2. Joint hypermobility, being very double-jointed. And 3. Fragile connective tissue, leading to things like easy bruising or poor wound healing.
How is it inherited?
Most types are autosomal dominant, but it's interesting that up to half of cases might be new, de novo mutations happening for the first time in that individual. The underlying issue is that abnormal collagen production weakens tissues throughout the body: tendons, ligaments, skin, blood vessels, even organs.
Are there different types we should know about?
There are several types, but the main ones to be aware of are probably hypermobile EDS, HEDS, which is the most common, mainly causing joint instability and pain; classical EDS, CEDS, which features more prominent skin hyperextensibility, fragile skin that splits easily, and abnormal scoring; and vascular EDS, VEDS, which is rarer but the most serious due to the risk of blood vessel or organ rupture. Life-threatening.
So, across the types, what are some common general manifestations?
Well, the skin hyperextensibility, being able to stretch the skin way more than usual, like maybe over 4 centimeters. The joint hypermobility can cause recurrent joint dislocations or subluxations, chronic pain, early onset arthritis. In kids, maybe delayed motor milestones because of instability. And the fragile tissue aspect can mean easy bruising, thin atrophic scars, cigarette paper scars, problems with wound healing. Cardiovascular issues like mitral valve prolapse or aortic root dilation can also occur, especially in certain types like VEDS.
Okay. Now, how does EDS compare and contrast with Marfan syndrome? There seems to be some overlap.
There is definitely overlap, which can make diagnosis tricky sometimes. Both are connective tissue disorders, often autosomal dominant. But Marfan syndrome is specifically caused by mutations in the FBN1 gene, which codes for fibrillin-1. Fibrillin-1 is crucial for forming elastic fibers in connective tissue. Think of it like the elastic bands that give tissues resilience and allow them to stretch and recoil.
So faulty fibrillin-1 leads to, what are the key Marfan features?
The most critical manifestations of Marfan are cardiovascular. Mitral valve prolapse is common. But the major life-threatening concern is progressive aortic root dilation. The base of the aorta stretches out over time. This can lead to aortic regurgitation, aortic dissection, a tear in the aorta wall, or aneurysm rupture. This is the main cause of reduced lifespan if not monitored and managed.
So regular heart checks are vital.
Absolutely. Yearly echocardiograms are standard practice to monitor the aortic root size. Musculoskeletally, Marfan typically causes tall stature due to overgrowth of the long bones. Arachnodactyly, those characteristically long, slender fingers and toes. Joint laxity is also common, similar to EDS, and scoliosis or chest wall deformities like pectus excavatum, sunken chest, or carinatum, protruding chest, are frequent.
And eye problems.
Yes, a key ocular finding is ectopia lentis, dislocation of the eye's lens, usually upward and outward. This is much more specific to Marfan than EDS.
So to summarize the comparison, both can have joint laxity, scoliosis, maybe aortic issues, but Marfan specifically has the tall stature, arachnodactyly, and lens dislocation, while EDS has more prominent skin features like hyperextensibility and abnormal scarring.
That's a great way to put it. While there's overlap in joint and sometimes aortic issues, those other features really help differentiate them clinically. although genetic testing is often needed for confirmation.
Okay, really helpful distinction. Now let's move into conditions involving the nervous system or potentially tumors, starting with neural tube defects or NTDs.
Right, neural tube defects. These are birth defects resulting from the neural tube, the embryonic structure that becomes the brain, and spinal cord not closing properly during early pregnancy. The two most common types are spina bifida, affecting the spine, and anencephaly, affecting the brain.
And there's a major preventable risk factor here, isn't there?
Yes, absolutely.
Yeah.
Maternal folate deficiency is a significant, well-established risk factor for NTDs. This is why folic acid supplementation is so important before and during early pregnancy.
Can you explain the basic difference in how they form?
Sure. Anencephaly is essentially a failure of the upper part of the neural tube to close, resulting in the absence of major portions of the brain and skull. It's incompatible with long-term survival. Spina bifida results from incomplete closure lower down, affecting the spinal column. The severity depends on what protrudes through the opening in the vertebrae.
Okay, so let's quickly outline the types of spina bifida.
The most severe and most common form is myelomeningocele. Here, both the meninges, the spinal cord coverings, and the spinal cord itself herniate through the defect in the spine. This usually causes significant neurological deficits.
Then there's a milder form.
Yes, spina bifida occulta. This is the mildest. There's a defect in the vertebrae, but the spinal cord and meninges don't protrude. Often there are no symptoms, maybe just a subtle sign on the overlying skin like a tuft of hair, a dimple, or a birthmark. And somewhere in between is meningocele, where only the meninges protrude through the defect, not the spinal cord itself. Neurological function is often less affected than with myelomeningocele.
And complications associated with the more severe forms.
Depending on the level and severity, you can see varying degrees of lower limb paralysis, bowel and bladder dysfunction, sensory loss, and often hydrocephalus, the buildup of cerebrospinal fluid in the brain, which might require a shunt. Again, underscores the importance of that periconceptional folic acid.
Definitely. Okay, shifting to a pediatric cancer, neuroblastoma.
Neuroblastoma. This is a cancer that arises from immature nerve cells, specifically from the sympathetic nervous system. It's often associated with amplification of an oncogene called N-MYC, which drives tumor growth.
Where does it usually occur?
Most commonly, it starts in the abdomen, often in the adrenal medulla, the inner part of the adrenal gland sitting on top of the kidney. But it can also arise in the chest, neck, or pelvis along the sympathetic chain. A key feature often mentioned is its tendency to cross the midline of the body, which can help distinguish it from some other abdominal masses in children, like Wilms tumor.
Are there any particularly distinctive signs or symptoms?
Yes, neuroblastoma can cause some unusual paraneoplastic syndromes. One is opsoclonus myoclonus syndrome, sometimes called dancing eyes, dancing feet, characterized by rapid chaotic eye movements and jerky muscle contractions. Other signs might include proptosis, bulging eyes, periorbital ecchymosis, raccoon eyes from bleeding around the eyes due to orbital metastasis, or even Horner syndrome if a tumor affects sympathetic nerves in the neck.
Wow, those are quite specific. Now, let's circle back to neurofibromatosis 1, NF1, which we mentioned earlier with cafe au lait spots. Remind us what it is.
NF1 is a multi-system genetic disorder, autosomal dominant, caused by a mutation in the NF1 gene. This gene normally produces a protein called neurofibromin, which acts as a tumor suppressor. It helps control cell growth and division. So when it's faulty, tumors can develop.
And the diagnostic criteria, we need at least 2.
That's right. Diagnosis usually requires at least 2 of the following key features. 6 or more cafe au lait spots, meeting those size criteria we discussed. Freckling in the armpits, axillary freckling or crow's sign, or groin, inguinal freckling. 2 or more Lisch nodules, those are benign pigmented hamartomas on the iris, usually seen on slit lamp eye exam. 2 or more neurofibromas, benign tumors growing on nerves, or 1 plexiform neurofibroma, which is a larger, more complex neurofibroma involving multiple nerve branches. Optic pathway gliomas, tumors affecting the optic nerve or chiasm. Specific bone abnormalities like sphenoid wing dysplasia in the skull or thinning of the long bone cortex, maybe with scoliosis. And having a first-degree relative with NF1 who meets these criteria also counts.
It's quite a list. Anything else seen maybe on imaging?
Yes, brain MRIs in children with NF1 often show areas of increased signal called unidentified bright objects, or UBOs. Their exact significance is still debated, but they are characteristic.
Okay. And how does neurofibromatosis 2 NF2 differ? Separate condition.
Completely separate, yes. NF2 is caused by mutations in a different gene, the NF2 gene on chromosome 22, which produces a protein called Merlin or Schwannemann, also a tumor suppressor. The absolute hallmark of NF2, seen in about 95% of affected individuals, is the development of bilateral vestibular schwannomas.
Bilateral, meaning tumors on the hearing and balance nerves on both sides.
Exactly. These benign tumors typically lead to hearing loss, tinnitus, ringing in the ears, and balance problems, often starting in the late teens or 20s, usually by age 30. People with NF2 are also prone to other nervous system tumors, like meningiomas and spinal tumors, as well as specific types of cataracts called juvenile posterior subcapsular cataracts.
So NF1 is more about skin findings and peripheral nerve tumors, while NF2 is primarily about those bilateral acoustic neuromas and other CNS tumors.
That's a good way to summarize the main distinction.
All right, one more for this section, Tay-Sachs disease.
Tay-Sachs, a truly devastating condition. It's a rare, autosomal recessive, lysosomal storage disorder. Lysosomal storage means that lysosomes, the recycling centers within cells, can't break down certain substances properly due to a missing enzyme.
And it's more common in certain populations.
Yes, it has a significantly higher incidence in individuals of Ashkenazi Jewish descent, as well as certain French, Canadian, and Cajun populations in Louisiana.
What's the specific enzyme deficiency in the substance that builds up?
The deficiency is in an enzyme called hexosaminidase A, or HEX-A, caused by mutations in the AEXA gene. Without sufficient HEX-A, a fatty substance called GM2 ganglioside accumulates, particularly in nerve cells in the brain and spinal cord. This buildup is toxic, causing progressive damage and destruction of neurons.
And the clinical course is relentless, especially the infantile form.
Tragically, yes. The classic infantile form usually presents around 3 to 6 months of age. An apparently healthy baby starts losing previously acquired motor skills. They stop rolling over, sitting up. They develop increasing muscle weakness, decreased alertness, and often an exaggerated startle response to noise, hyperacusis. Over time, this progresses to seizures, blindness, paralysis, profound intellectual disability, and neurodegeneration. Death usually occurs by age 3 to 5 years.
And the eye finding.
The classic eye finding on retinal exam is the cherry red spot. This is the macula appearing bright red surrounded by a paler retina where the gangliosides accumulated in the nerve cells.
Is there any treatment?
Unfortunately, no cure or effective treatment exists currently. Management is purely supportive, focusing on symptom control, nutrition, and comfort care. Genetic counseling and carrier screening are important for affected families and at-risk populations.
A very sobering condition. Okay, for our final section, let's focus on a critical skin condition that requires urgent management. Staphylococcal scalded skin syndrome, SSSS.
Right, SSSS, also sometimes called Ritter disease, especially in newborns. This is a serious, superficial blistering skin condition. It's not a direct infection of the skin itself, but rather caused by exfoliative toxins produced by certain strains of Staphylococcus aureus bacteria elsewhere in the body.
So the bacteria might be somewhere else, like the nose, but the toxin spreads through the bloodstream.
Exactly. The toxins, exfoliative toxins A and B, circulate and target a specific protein in the skin. It's most common in infants, often in the first week of life, 3 to 7 days old, and young children under 5. Their kidneys aren't as efficient at clearing the toxin, and they may lack protective antibodies. It can occur in older children or adults, but usually only if they have significant kidney problems or are immunocompromised.
What protein do the toxins target? How does that cause blistering?
The toxins specifically target and cleave a protein called desmoglein-1. Desmoglein-1 is a key component of desmosomes, which are like cellular rivets, holding the cells of the epidermis, the top layer of skin, together. By breaking down desmoglein-1, the toxins cause the connections between skin cells in the upper epidermis, specifically the stratum granulosum layer, to fail. This leads to widespread detachment and the formation of fragile superficial blisters.
That sounds like it could spread very quickly. Can you describe the progression? It happens in phases, right?
It does, and it can progress rapidly, often over just a day or two. It typically starts with the erythema phase. The child suddenly develops fever, irritability, and skin tenderness. Then a widespread bright red rash appears, often starting around the mouth or in skin folds like the neck, armpits, or groin. The skin blanches.
Okay, redness first, then the blisters.
Yes. Next comes a bullae phase, usually within 24-48 hours. Flaccid, meaning floppy or wrinkled, sterile blisters form on the red skin. These rupture very easily, leaving moist, red erosions. This happens especially in areas of friction or pressure. And the key sign is the positive Nikolsky sign.
What's that?
Nikolsky sign is when gentle rubbing or pressure on apparently normal skin causes the top layer to separate and peel off. It shows how fragile the skin adhesion is. You also often see characteristic crusting and cracking, like radial fissures around the mouth, nose, and eyes.
And after the blistering.
Finally, you get the desquamative phase. Large sheets of the superficial skin peel away, leaving extensive areas of moist, denuded skin that look scalded, hence the name. Fortunately, because the split is very superficial within the epidermis, healing occurs relatively quickly, usually within 1 to 2 weeks, and typically without scarring, as the deeper layers aren't damaged.
Given how severe and rapid this is, immediate management is crucial, I assume. Hospitalization.
Absolutely critical. SSSS is a medical emergency requiring immediate hospitalization. The mainstays of treatment are intravenous antibiotics to eradicate the toxin-producing Staph aureus infection, even though the blisters themselves are sterile. Usually a penicillinase-resistant penicillin like nafcillin or oxacillin is used. If MRSA is suspected or prevalent, vancomycin or clindamycin would be necessary. Supportive care is equally vital. Meticulous fluid and electrolyte management because of fluid loss through the damaged skin, pain control, and gentle skin care to prevent secondary infection of the raw areas and promote healing. Using emollients helps.
But the outcome is generally good with prompt treatment.
Yes, thankfully. With appropriate antibiotic therapy and supportive care, most children recover fully within about 2 to 3 weeks, typically without any long-term skin problems or scarring. The mortality rate is low in children if treated promptly, though it can be higher in adults with comorbidities.
Wow, what a journey through these pediatric conditions. We've really covered a huge range today. From those very common and thankfully benign newborn rashes that mainly just need reassurance, all the way to these incredibly complex genetic syndromes that can really impact almost every body system, and finishing with a critical condition like SSS that demands immediate recognition and action. Our goal with this deep dive, as always, was to give you that shortcut, that efficient way to get genuinely well-informed on these key pediatric topics, pulling out the core knowledge from practical sources.
Absolutely. And reflecting on all this, it really brings up an interesting question for you, our listeners, to think about. How might a deeper understanding of these earliest signs, the subtle skin finding, the newborn presentation, the genetic predispositions, how might that really reshape our approach to pediatrics? Could it push us towards earlier interventions, maybe even preventative strategies, potentially before significant symptoms even develop?
That's a really powerful thought. The potential impact of early recognition and understanding the underlying biology, something definitely worth considering. Thank you for joining us on this deep dive. We hope you found it insightful, and we encourage you to keep exploring the deep dive.